All right, so let's talk about newborns. So you're working in the ER, or you're in an urgent care, and mom walks in with a critically ill baby. Got a critically ill 9-day-old. Baby had a term birth, good prenatal care. Baby's had a 1-day history of decreased feeding and vomiting, and then baby became unresponsive, and mom called 911. You find in front of you a mottled, cyanotic, unresponsive infant. Baby's tachycardic. You try to get a blood pressure. You have a right-sized cuff, and you have nothing. Baby's breathing fast, the O2 sweats are terrible, and the baby's afebrile. And this is where you question your whole idea of going into medicine, right? Who's coming on? Who can I call for help? So this is a mnemonic I use. We could spend an hour on each one of these diagnoses. We're going to do these in a half an hour. So this is not a full scope lecture on all of these. This is to remind you of stuff that you might not have thought of since your early training. Sepsis, inborn errors, congenital adrenal hyperplasia, heart disease, CNS hemorrhages, formula mix-ups, intestines, and disasters. You're going to think sepsis, 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 and any critically ill baby, but you want to have a differential because there are other things that happen. And if you don't think about congenital adrenal hyperplasia, you may not think about it when you see the electrolytes. Or if you don't think about inborn errors of metabolism, you not remember to order the ammonia. So it's sepsis till proven otherwise. Any ill appearing, whether you're 9 days old or you're 90 years old, is septic until proven otherwise. And again, the same rule, if you're 9 days old or 90 years old, you may not mount a fever, and yet you're still septic. Again, the definition of a temperature in this age is 38 and above, but remember, you can be afebrile and yet septic. Again, and the ends of life, that rule applies. The infections they get at this age, we already talked about this morning: meningitis, pneumonia, UTIs. The bacterial pathogens haven't changed. The viral pathogens haven't changed. They're all still out there. What are signs and symptoms of a sick, septic baby? Temperature instability. Again, they can have fever. They can be hypothermic. The temperature, look at that temperature of 36. Don't just count it as, oh, the nurse took the temperature wrong. They can be lethargic. They can be irritable. They can have seizures. They can be apneic, breathing too fast, breathing too slow, vomiting, poor feeds. Sick babies can turn yellow. This is not a well-appearing baby in front of you. We talked about this a little bit this morning. Do a good search on this baby who's critically ill in front of you. Look for signs of herpes, little lesions. Look at the belly button area for umphilitis, that surrounding redness, which tends to be multiflora. So you're going to get a line. Everybody has scalp veins. You don't put the tourniquet around the baby's neck. You put the tourniquet around here. You can dump a whole lot of fluids into scalp veins. Everyone has a vein between their 4th and 5th metacarpal, and you can put a IO in. There's no reason why you can't do an IO in a newborn. The little pink needle of the Easy IO is what you can use. You need to bolus them, 10 cc's. It's little small aliquots of stuff. Normal saline, get an AccuCheck. D10 is your corrective fluid. You can take D50 and dilute it if you need to. You get urine. Again, be very careful about taking a very, very sick baby and scrunching them in a ball for an LP. Get urine, get blood, give them antibiotics. You can get the LP later. Resuscitate that baby first. You're going to give them antibiotics, typically Ampigen. If they're really sick, Cefotax has a little bit better CNS penetration. First couple of weeks of life, especially the first week of life, maybe not ceftriaxone because it can sludge that bilirubin. Give them Vanco if they're an ex-NICU baby. They've spent some time in the hospital more than just being delivered because they're more at risk for some resistant organisms. And think about herpes. There's not a neonatologist. If you had a sick, ill-appearing, seizing neonate, think about herpes. There's not a neonatologist that will fault you for giving a dose of acyclovir. But if it ends up the baby has herpes and you didn't, so if they have a fever plus a seizure, think herpes. If the mom has herpes, if you do the LP, again, on a more stabilized baby, and they have a lot of white cells, but a negative gram stain, think about herpes. Again, if they have umphilitis, you're going to add an more anaerobic coverage, and you're going to admit them to the hospital. So it's sepsis, sepsis, sepsis. Now we got to think about the other things. So inborn errors of metabolism. This is a hereditary biochemical defect that results in the accumulation of a toxic metabolite. Some of us may have a low-grade inborn error sitting in this room, but it's not. We don't accumulate enough for it to be clinically relevant. It's when it rises to the level that it's clinically relevant. And those toxic metabolites tend to be ammonia, ketones, lactic acid. If you had to bet one, it met ammonia, and the organ system that it tends to penetrate or tends to coalesce in is the CNS. So they present vomiting, altered, lethargic, seizing. You'll see a theme here for the diseases we're talking about. Ask about deaths of seedling. You got this sick 2-week-old, a sick 1-month-old. Tell me about your other children. Sometimes, if it hits one kid, it doesn't always hit every child, but if it hits one kid and was lethal in the first few months of life, it may not have been explained. We had a kid, he was well when he was born, he just dwindled and died. It might have been an inborn error that was never figured out, and now they have a second kid. If it was lethal in that first kid and the second kid has it, may skip a kid, but the next kid that has it is probably going to be lethal in that child too. So ask about previous deaths of siblings that may have been unexplained. They present dehydrated, they can have large livers, they can smell funny, like tomcat urine, chlorine like in a swimming pool. So if they smell something other than a poopy diaper, think inborn error. They can have elevated ammonia, ketone, lactic acid levels. Again, if you have to pick one, pick ammonia. They're not always acidotic. They can have low, again, any baby looks cross-eyed at you, you're getting a sugar on them, giving them D10 if they need it. And certain inborn errors will have this erotic acid crystals. But you want to think of this disorder, especially in an afebrile, vomiting, altered baby. The key to the key to treatment is we want to give them something other than, usually it's protein where they have the problem. So you want to give them another energy source, sugar and saline. So give them normal saline and D10 boluses as they need it. Get them euglycemic and euvolemic. And then you want to put them on something other. They want to eat another energy source. So put them on D10 at quarter normal saline drip, a little bit faster than your maintenance rate. Remember, it's 10 cc's per kilo per hour. So a little, we want to do a little bit normal, then a little bit faster than maintenance. You could give them bicarb. This is where I'm getting on the horn with a specialist. There's not a PICU person in the world that wouldn't help you manage this baby. So know where you're going to send the baby. Get on the horn with a PICU doc. Give them what you got, the vitals, this baby in front of you. I'm concerned. Maybe you got the ammonia level back. Let's say it's high. There's not a PICU person worth his weight that won't help you walk through this. Let them decide if bicarb, and they have some other antidotes out there that can be given. Save a red and a green top tube if possible. I call them those digitubes. So they say, did you get the blank test? Yes, I can now get it for you. Especially before you've given the saline and the sugar and all that stuff. Because sometimes it's easier for them to figure out where in this biochemical pathway is the problem. Congenital adrenal hyperplasia, that's the adrenal insufficiency. It results also in an enzyme deficiency. It results in a deficiency of cortisol and aldosterone, and a lot of times an accumulation of androgens. So they're low on cortisol, they're low on aldosterone, so they get the blood pressure and the electrolyte problem, and then they have this accumulation of the androgens that cause sex steroids. It usually, again, presents in the first couple weeks of life. How do they present? You'll see a theme. Decreased POs and vomiting, altered mental status. They present dry, altered. The babies, little girl babies, because of if they're going to accumulate the androgens, if they happen to have that pathway, they're going to look a little externally not normal. The little girl babies are likely to be caught in the newborn delivery room, the newborn nursery. Like someone's going to look at that and go, that's not normal. I'm going to keep that baby in the hospital. The little boy baby, he looks externally pretty normal. He's got mom's cortisol running through him. He gets blessed and goes home, on day 2 of life. And then comes back in the first week or so of life after mom's cortisol level plummets in his system. So you're more likely to see a little boy baby coming in your ER than a little girl baby, just because of the external genitalia sometimes clue. They can present cardiovascular collapse because of the lack of cortisol. They can present with low sodiums and high potassiums, again, because of that hormone loss. And the Ks can be high, 7 or 8, and yet they tolerate it really well. Get an EKG on them, sure, but they don't look like they're having any change to their EKG. If they do, you treat it the same way. If not, it's really about fluids. A lot of them, the Ks will come down nicely with just some fluid resuscitation. Their BUNs can be high, they can be acidotic, they can have reducing substances in their urine. Well, that's non-specific because we see that a lot in even normal kids. It's about the electrolytes. Look at that low sodium and the high potassium is the clue. And if you give them, if they're looking altered, they look like they have poor perfusion, they look dry, and you give them a fluid bolus challenge, 10 per kilo, 20 per kilo, I'm now on 30 per kilo, and they're just not responsive. That's a cortisol problem. The treatment, again, is rehydration and glucose, and the dose for a term baby of hydrocortisone is 25 milligrams. That's the drug they need. Again, the Ks are usually well tolerated, even though they're 7 or 8. They've lived this for a little while. Doesn't really affect their hearts as much. A K will come down nicely on its own. Again, save a red and green top. So they can again get more biochemical studies, especially before you give the hydrocortisone, before you dilute it if you can. Congenital adrenal hyperplasia. So, congenital heart disease. So there's 3 categories. We'll talk about, again, each one of these can be a category or diagnosis or a lecture on its own. So there's the first group that are the ductus arteriosus dependent lesions. And that's where this, right there. So they get that, there's a natural opening between your pulmonary artery and your aorta because you don't want blood going to the lungs when you're a fetus. So it goes out the pulmonary artery to the aorta via this little ductus and goes out to the systemic circulation. That's normal, fetus. That's supposed to shut down though, right? It shuts down. In some babies, they have a structural abnormality and they need that ductus to stay open to generate circulation. We'll talk about that. And it's when the ductus shuts down normally that these babies then get into trouble. And it's usually in the first week of life. They can present blue, they're called their cyanotic babies, or they can present gray as kind of shocky cardiovascular collapse. There's 2 different kind of structures. This is all kind of big picture. You also have your left or right shunts. These have nothing to do with the ductus. They're like your VSD kids. They present a little bit later, end of the first month of life, second month of life, because these babies are kind of slowly put into congestive heart failure. We'll talk about it. And the third group is your arrhythmias, like your SVT. So let's talk about your ductus. So they usually present in the first week of life when your ductus normally shuts down. Normally when your ductus shuts down, you don't have a problem because you don't have a congenital heart disease. But if you needed that ductus to supply blood to the lungs or to supply blood to the systemic circulation because you have an abnormal anatomy to your heart, you're going to get into trouble when the ductus shuts down, and it generally occurs in the first week of life. So you can have babies where the ductus is needed to supply blood to the lungs, and when the ductus shuts down, they turn blue, and they come in and they're cyanotic. Or you have a group of babies who have a different structural abnormality. They needed the ductus to supply blood to their entire systemic circulation. So when their ductus shuts down, they come in looking shocky. And it can be really hard sometimes to tell the difference between that and a septic baby. So let's talk about the right to left, the cyanotic babies, that first group. The ductus shuts down, they go blue, cyanotic. Those are the right to left intracardiac shunts. Blood is going from the right side of the heart to the left side of the heart, completely bypassing the lungs. They needed the ductus to stay open to supply blood to the lungs so they can oxygenate their lungs, oxygenate their blood. They have what's typically known as right-sided heart lesions, your tetralogy of Fallot, your tricuspids, things like that. They needed the ductus to stay open to supply blood to the lungs, and when the ductus shuts down, the babies get into trouble and they present cyanotic. They may or may not have a fever, or have a murmur. So if you have a baby who comes in and they're suddenly cyanotic, think congenital heart disease. It may not be pulmonary. We'll talk about some clues for the difference. Congenital heart disease is on there. Pulmonary, is much more likely the cause. They have RSV, they have a pneumonia, but congenital heart disease is there. So the terrible T's are the ones we know about that cause this sudden cyanosis when the ductus shuts down, things like tetralogy, tricuspid atresia, your transpositions, total anomalous, and truncus arteriosus. It's right-sided lesions where the ductus is needed to supply blood to the lungs. So how do you tell the difference between cardiac and pulmonary? Well, babies that come in and it's a pulmonary reason for their hypoxia, you put the O2 stat on and it's 80, they're generally going to have signs of pulmonary disease. They're retracting, they're tachypnic, they're grunting, they have crackles on exam. Babies that it's cardiac generally don't have that. Babies where it's pulmonary, if they cry, they increase their minute ventilation. Their tidal volume is much bigger. Their lungs are expanding because they're screaming. In general, their O2 sat will go up because they've increased their minute ventilation. If you put them on oxygen, if it's pneumonia or RSV and the SATs were in the 60s and you put them on a non-rebreather, what happens to the pulse ox? It generally goes up a lot. But if it's cardiac, you can put them all the oxygen in the world and you won't get a significant bump, a couple of points. So there's something actually called the hypoxia test, where you either do blood gas, and now that we have pulse ox, you don't really have to do blood gas, but you're looking for a significant rise in that pulse ox when you put the baby on oxygen. And you don't see it, start thinking, I might have a right to left shunt going on here. Methemoglobinemia is out there. There's something called congenital methemoglobinemia, severe, any once in a while, severe diarrhea will trigger this diarrhea episode. Baby looks cyanotic or looks blue. Certain toxins, some of the topical anesthetics can cause it in certain babies that have a congenital risk for it. The other group of the ductal ones are the ones where they present shocky because the ductus is needed to supply blood to the outflow of the heart, to the systemic circulation. So these are left-sided heart lesions, your coarcs, your aortic stenosis, your hypoplastic left heart. They need the ductus to stay open to supply blood to the systemic circulation, the rest of the body. And they get into trouble when the ductus shuts down. They can present pale, shocky, with diminished pulses, not peeing and altered. Looks like sepsis. Can be really hard to tell the difference. If the baby's not febrile, this needs to be on your list. Coarc, where it's that narrowing of somewhere in the aorta, and it kind of depends on it. A lot of times it's right where the ductus is, which is weird. And so when the ductus gets low, the coarc was actually supplemented by that ductus. So now they have a double whammy. They got the ductus shutting down, and now the coarc gets into more trouble. And coarc babies can have diminished blood pressures, O2 sats, or pulses in their lower extremities. So make sure when you're seeing a critically ill baby that you're checking pulses up here and checking pulses down here, not just here, because the coarc could be more distal. So check the pulses distally, check the pulses proximally, check blood pressures, check pulse oxes. They might have a gallop, they could have a big liver, cardiomegaly. Remember we talked about the lateral. Sometimes it's hard. Our residents are getting really good bedside ultrasound. They can go in and say, hey, this looks like a 4-chamber heart. It's really nice to have that modality in the ER. These were some of the x-rays we talked about yesterday. Sometimes you get a clue on a chest x-ray. A lot of times in little babies you don't, because they have a thymus that's really big. This is the boot-shaped heart of tetralogy of Fallot or the tricuspid atresia. Transposition of the great vessels. They have a bulbous heart with a very narrow mediastinum. Again, sometimes it's hard to tell in babies less than 6 months of age because they have a large thymus that takes up the whole mediastinum. And then total anomalous pulmonary venous return. It looks like a figure of 8 or a snowman. So it's a bulb here and a bulb down there. Sometimes you get a clue from the chest x-ray, not often. How do you manage the ductal dependent lesions? They need to be on a cardiac monitor. They need IV access, obviously. Umbilical veins are great. Interosseous, there's no reason why you can't do it in neonate. Prepare to manage their airway. The drug they need is prostaglandin. It's a very potent vasodilator, specifically at that. The ductus tissue is really, really sensitive to it. There's a lot of side effects to it, apnea, fever, hypotension. A lot of transport teams, if they know a baby's on prostaglandins, they'll prophylactically tube the baby because they don't want them to stop breathing while in the back of the ambulance. Some of these babies need to be on dopamine. Again, this is where you want to be on the whole. You want to know if a sick baby walks into my ER, who am I calling? Again, there's not a PICU person in the world that won't help you walk you through this. It's just remembering, hey, there's congenital diseases out there. They can present cyanotic. They can present what looks like sepsis, poor perfusion. Hey, the kid doesn't have a fever. The other group of structural lesions are the left or right ones. These present in the second week of life or later. Things like VSDs and ASDs. It's blood flow from the left side of the heart to the right side of the heart. When the baby's first born, they have high pulmonary vascular resistance. That's normal because we didn't want blood going to the lungs. And then it gradually dissipates over the next month. That's normal. And we allow more and more blood flow to the lungs. If they have an existing left to right shunt, as that vascular resistance goes down, more and more and more and more blood is going to be funneled to the lungs, and the baby's slowly going to be put into congestive heart failure. It's not one of those kind of more rapid things like the ductus. The baby slowly gets put into congestive heart failure. So mom will say, and that just shows the VSD right there. There's just that little opening there. So it's left to right movement in the heart. They're going to present with poor or slow feeding. This may happen over a few days, maybe a week. They'll sweat when they feed. They don't do much except eat. That's their cardiac stress test, and they're failing. They can have color changes when they're eating. They have poor weight gain. We call them our pink babies. They're not cyanotic. They're just slowly being put into congestive heart failure. The differential includes congestive heart failure. SVT we'll talk about. Most babies with SVT present fine. They may be profoundly anemic. They could be septic. Metabolic derangement can sometimes present with CHF symptoms. Neonatal lupus, neonatal thyrotoxicosis. They need an echo, a great bedside ultrasound. Will tell you if this baby's got a 4-chamber heart and what that ventricular septum looks like. Is there flow between? A lot of times they need Lasix, dopamine, dobutamine. Again, getting on the horn with your cardiac person or your PICU person can be very, very helpful. We talked about this yesterday, some other clues to congenital heart disease. The trachea is normally deviated to the right of your chest because you have a left side aortic arch. If your trachea is deviated to the left on the x-ray, you might be dealing with a right-sided aortic arch, which is a marker for congenital heart disease. The other one is dextrocardia or situs inversus. Those have high rates of congenital heart disease. So you throw up the film and you're like, did they put the marker backwards? No, that was dextrocardia, and the kid has a marker for congenital heart disease. SVT, these babies present often well appearing. They're a little fussy. My friend had a baby, 6-month-old, little fussy, didn't take his bottle. She lied him down for a nap, she put a hand on her chest, on the baby's chest, and it felt like a train was running through it. She took the baby to the ER and his heart rate was going 280. They just present a little, I'm not happy. They're often alert, they have good pulses, they're just going really, really fast. If they're unstable, you shock them, but that's super rare. Most of these babies are around looking at you, their heart rate's going sky high. You can utilize that dive reflex. And I looked at one study, and they said, you know how we do with adults now with SVT? We're doing the sit up, lie down, legs up. You do that with a baby too. Sit them up, put the face on, and lie back down. And you're taking that same response that we see in adults, seems to work with babies. You get a little bit higher rate of return. Or you can give them adenosine. And get on the horn with a pediatrician, get on the horn with. Most babies convert really readily, and again, they present not ill-appearing at all. Central nervous system bleeds, AVMs, child abuse. There are people that will beat on a 6-week-old, on a 3-week-old, especially colicky babies. If that mom comes in and that baby it's clearly colic, it's daily, it's hours of crying, and the baby's otherwise doing well, eating, colic, you want to be careful about making the diagnosis on one day of a crying. It's typically a pattern. Look for that mom that's not coping. My sister-in-law, who is president of many, many companies you've heard of, wanted to throw my, 2-month-old nephew through the window because he had bad colic. It can take the best of us and just bring us to our knees. Vitamin K deficiency, for some reason, Mother Nature forgot the vitamin K, and if you don't get a vitamin K shot when you're born, every once in a while, a baby has some type of coagulopathy. But they generally won't present with just a single organ. They'll have skin bleeding, GI bleeding, CNS bleeding. Formulas, I'm a mom, I was tired. You can mix up your formula, right? They have the ready to eat, you're adding too much water, you mix up the powder, you don't know how to mix it. I always blame the mom because I'm a mom, it's okay. Ask how they're mixing it up. If you don't ask, they're not going to volunteer it. They're not going to know they did it wrong. How are you mixing up the formula, mom? Are they giving anything else? That's where you have to bring in the aunt or the grandma, because sometimes they're giving stuff, the mom doesn't even know. Grandma walks in, of course, yes, I've given everybody. I've put a baking soda in every child's bottle. What's wrong with that? Works for colic. No, that's why he's seizing. So if you don't ask, they're not going to tell you. And the last is intestinal disasters, incarcinated hernias. You got to do a good physical exam. Look for that bulge, look for that scrotum. Diaphragmatic hernias, we talked about that a little bit yesterday. Those that's where, your bowel is in your chest. Most of those present in the delivery room in the neonatal nursery because the baby has respiratory distress, depending on the amount, right? They have a scaphoid abdomen. Those babies get jumped on pretty quickly. But if it's not that, we talked about yesterday, there was a film of a guy who had born with it. It was on the right side, very atypical. They tend to be on the left side. But if it's not that bad, the babies can go home and get discharged. And then they come in with, a little RSV or something, that gave them low pulmonary, gave them a lower lung field disease like RSV, went to the lower lungs, and now they get tipped over and they come in. Necrotizing enterocolitis, that's kind of the bacteria in the wall of the bowel. That tends to be in our NICU babies, our premature babies. But every once in a while, you'll have a baby that comes in term, but it tends to be in our NICU babies. Volvulus is what we want to kind of mention here, because this is in well-appearing babies who went home and now come back in the first couple of weeks. There's a big risk for it in that first month of life. If they're born with that malrotation, the Mother Nature didn't tack their GI system down, their intestines down as well as they should. They didn't do the normal, I think it's 260-degree turn that they're supposed to. They didn't get tacked down, so they're at risk for complete twisting, the volvulus. So it's a result of a congenital malrotation. That malrotation that they're born with puts the bowel at risk for volvulus, which is the actual twisting. So they're born with the risk, and then it ends up twisting. Not everybody with malrotation ends up with volvulus. But the highest peak, or a high peak, is when they're in that first few weeks of life. This is a true medical emergency because time is bowel. It's twisted and it's infarcting. They can present with abdominal distension. They can present with vomiting. They'll talk about like a blue abdomen because you see ischemic bowel. Don't wait for that. Think about it in the vomiting 2-week-old. If it's bilious vomiting, you need to worry. Bilious vomiting in a newborn is never good. It is not AGE. Worry about, be careful making the diagnosis of AGE in this age group. Because if it's not bilious yet, it may be. But if it's bilious, you need to be on the horn with that ped surgeon. Call your pediatric surgeon early. Those babies need, time is on the bow. Antibiotics don't treat this. They need to go to the OR. This is what you might see on a plain film. This is called the gasless abdomen. Sometimes you'll see what's called the double bubble sign. You get like a big stomach bubble and a little bit in the duodenum, and everything else is gone because basically everything distal to the twist has gone out the other end, and they just keep air stacking proximal to it. So they get a lot of proximal air, but not a lot going on down here. They call it a gasless abdomen. Here's the double bubble sign. Double bubble. If the baby is more well-appearing, is vomiting in the first couple of weeks of life, it's not bilious, but it's on your differential, then the test of choice is an upper GI. I'd get on the horn with a ped surgeon and kind of do this kind of collaboratively, but the test of choice is an upper GI, and they're actually looking for this twisting, that corkscrewing. If you're seeing this, the ped surgeon should be pulling into the parking lot. That's pathognomonic for it, and the baby needs to come into the hospital, the baby needs to go to the OR. Call the ped surgeon, IV access, hydrate that baby, give them antibiotics because they probably have some type of dying bowel, multiflora again, and those babies need to go to the operating room. So your take-home points is know the differential for a sick neonate. It's sepsis, 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 sepsis until it's not. And if you don't know what are the other things going on in the first month of life, it's good to have just a working mnemonic. So sick fit works for me. Keep neonates warm. We rip off babies' clothes. They have higher body surface areas than we do. Make sure they stay warm. Bring down the warming lights. Check glucose early. If they look cross-eyed at you, get a glucose on them. Anything less than 40 or 60 generally, give them a little bit of D10. Don't forget about umbilical lines, interosseous lines. There's no reason why you can't do it, and the little pink ones in the EZ-IO are for them. Call for help early and know ahead of time where you're going to send a sick baby. The worst is to look up from that sick kid that you've just tubed and say, and I only work here once a month. Where do we send sick kids? Know ahead of time and have that conversation ahead of time. And then you have to be prepared for any neonate that comes in. This was a 2-week-old chimpanzee. We took care of it in my department. And with that, I thank you very much.